So our final speaker today is Tamas Gonda. He's got his medical degree from Dartmouth, did his residency at New York Presbyterian Weill Cornell, his fellowship in gastroenterology at New York Presbyterian Columbia, and is now a professor in the Department of Medicine at NYU Grossman School of Medicine. He's the chief of endoscopy at Tisch Hospital, and he's the director of the Pancreatic Disease Program.
Thank you so much, and thanks very much to the organizers for the opportunity to speak. It's not often that a talk about screening for cancer is at the end, so it's hopefully you'll actually understand why I think that makes sense in this particular disease, because it may be one of the more impactful ways. I also just want to say one disclaimer. I'm really honored to be part of this meeting and to talk to you about especially the aspects of disparities in the context of pancreatic cancer screening. It is not something that was originally my sort of research focus, but as someone who runs the clinic now for pancreatic cancer screening for several years, it was very quickly obvious to me that this is something that we have to look at. Because despite as you have seen, the obvious diversity of patients who are diagnosed with pancreatic cancer, for many years, I saw an entire, and to a large extent to this day, I saw a very, very different population in a very busy screening program, which is completely disconnected. So one of the things I will talk about is an effort that we have started at our institution to kind of change that and to really make sure that even in the screening population, or even in a screening program, we screened everyone and expand our screening program to reach everyone. So very quickly, I will walk through, and I know it's the last talk, so I'll try to be brief on some of these slides. But I will walk through, why pancreatic cancer screening is important. It is not a disease where screening guidelines are solidly established. It's still very much evolving. I'll talk a little bit about screening approaches, disparities in screening, and as I mentioned, approaches to identifying patients from the entire general population. So you've seen some variation of this slide. The point here is that this is, again, a terrible disease, but the small but is that when diagnosed at a very early stage, at stage 1, survival is significantly different. These are some of the most important survival curves for this talk, because I think it gives context to the important question of, is it even worth it to screen for pancreatic cancer? And I think the graphs here show, again, when you can detect it early and when you can remove it surgically, survival is significantly better. That's the graph on your left, or on the side left. But most importantly, the 3 graphs on the right of the slide show that when we actually find pancreatic cancer in an organized screening program, in many different measures, we outperform, or patients do significantly better in terms of their survival than where matched patients are identified when they present with pancreatic cancer. So this is a little bit of a, I'm not an epidemiologist, but this is a bit of a back of an envelope kind of calculation to point out an important concept. This is a very rare cancer. So it is found in about 12 to 13 per 100,000 in the population. And with such a rare cancer, no matter how good your test is, no matter how perfect the screening test is, your likelihood of detecting a ton of false positives is perhaps unacceptable. And this is why general population-based screening for pancreatic cancer is not recommended, and why the approach has been to try to identify populations that have a significantly higher risk when they enter into a screening program than the general population. That higher risk is kind of expected to be somewhere between 5 to 10-fold the general population risk. And this is the other problem with this cancer. So unlike many cancers where we have strong identifiable risk factors, whether it is smoking or other factors, there are no such risk factors for pancreatic cancer. The risk factors that are identified have very, very little incremental increase in risk. So smoking does not distinguish patients being at risk for pancreatic cancer versus not. So unlike in lung cancer, it wouldn't be a way to guide screening recommendations. But we do have a couple of things, and those are highlighted here in the bottom, which are very important, and I'm going to talk about it, at least about some of them, that increase the risk of pancreatic cancer. So the first, so sort of to step back a little bit to the biology and what we know about how pancreatic cancer forms. What is it actually that we're looking for? So the majority of pancreatic cancer, which is the bottom half of this slide, forms on this pathway of pannin lesions or pancreatic intraepithelial neoplasia to becoming a ductal adenocarcinoma. What is important from a practical standpoint, and I'm ultimately a clinical gastroenterologist, so in a very sort of practical clinical way, what's important about this pathway is that until you develop an actual cancer, this is what I would refer to as an invisible precursor. You cannot, for our current technologies, don't allow us to see the precursor lesion. So you don't have a colon polyp analogy where you can find something that develops before the development of pancreatic cancer. A minority of patients develop pancreatic cysts, which is a slightly different pathway to the development of pancreatic cancer. I'm not going to talk about cystic lesions today, but when one is found with a pancreatic cyst, that allows a slightly different algorithm for screening. So what is the current goal, today's goal of screening for pancreatic cancer? Again, for the majority of patients who will develop pancreatic cancer on this invisible precursor pathway from pannin lesions to pancreatic cancer, the goal is to detect very small, curable and resectable, but cancers, not precursor lesions or not precancer lesions. How do we identify the population where we can find potentially patients that have this elevated risk, baseline risk of pancreatic cancer, and whom we can screen for early pancreatic cancer? The first strategy is, again, to enrich the population and to look for patients who are at a higher risk for pancreatic cancer. And the way we do that is to look at genetics and family history. Where did this come from? It came from looking at it the other way around. How often are germline mutations, or how often is family history identified in patients who are diagnosed with pancreatic cancer? And these are two large studies that basically profiled every patient in these cohorts and asked how many of them had a germline mutation, how many of them had a family history. And the numbers that came out is that somewhere between 8 and 10% of patients with a diagnosis of pancreatic cancer will have a germline mutation, and somewhere around 8% of them will have a significant family history of pancreatic cancer. So in 2019, actually, but then it was, I think, revised in 2021, the National Comprehensive Cancer Network, based on some of these data, made the recommendation that if somebody does have a diagnosis of pancreatic cancer or has a first-degree relative with a diagnosis of pancreatic cancer, they should undergo germline testing to identify them as potentially or as potentially eligible for screening for pancreatic cancer based on the presence of germline mutations. This slide summarizes some of the germline genetic mutations that are relevant for pancreatic cancer screening. And what is interesting is that essentially all of the mutations fall into two groups of diseases or hereditary cancer syndromes, one that is related to breast cancer, the BRCA genes, and some other related genes, and another that relates to a Lynch syndrome, which is another hereditary cancer syndrome. And then there are 2 or 3 additional very high-risk mutations that are considered to be at risk for pancreatic cancer. This is sort of the rough estimate of what are the risks with each of these mutations carried by an individual of developing pancreatic cancer. And this sort of is the basis for who should undergo screening for pancreatic cancer, with the idea that if one is identified to have a germline mutation in any of these genes, consideration for pancreatic cancer screening should be given based on, again, the elevated relative risk somewhere in the 5 to 10%, 5 to 10-fold range. What about family history? Is it important to have a family member? Is it important to have more than one family member? So as it turns out, if you have one family member, your risk is elevated, but perhaps not sufficiently elevated to hit this 5 to 10-fold mark. When you have multiple family members, doesn't seem to make a huge difference whether the cancer occurs in your in a family member at a young or an old age. But when it occurs in a family member, in multiple close family members, first-degree relatives, the risk of pancreatic cancer, to some extent, regardless of whether we can identify a genetic mutation, is significantly elevated. And then this is just sort of a little bit more of a detailed analysis of when you combine these things. So you have a family history, you have a genetic mutation. Is the presence of a family member, is the presence of a mutation important? And the take-home message from here is that it is actually very important. The risk of developing pancreatic cancer in an individual who has a family history but no identifiable or known genetic mutation is actually quite low, whereas if they have a family history and a genetic mutation, the risk is significantly higher. So again, to drive home the point that germline testing for mutation for the known mutations associated with cancer seems to be a very important way to screen individuals. Oops. Okay. Sorry, this was not expected. Okay, so this is just a summary of what is the current recommendation. And I think the top line is important. At the moment, in the general population, screening is not recommended. However, if you have some of these pathogenic germline mutations, or you have a significant family history, screening is recommended. How do we do screening? I'm going to skip this set of slides for the moment, just to say that there is two essentially, imaging is what drives screening for pancreatic cancer. There's non-invasive imaging, which is done with magnetic resonance imaging, which is an MRI. It's thought to be it is a harmless cross-sectional imaging study. And there's endoscopic ultrasound, or EUS, which is something that I perform a lot, which is a very detailed endoscopic and therefore a little bit more invasive way to examine the pancreas. Head-to-head studies are quite rare between which one is better. I think the general notion in the field is that the two complement each other. I'm not going to bore you with these are very exciting images for me, but I don't think I need to bore you with some of the finer details of this. But to say that again, we're looking for quote unquote invisible precursors. So this is a very difficult exam in the sense that you need very good equipment and you need very experienced operators to find tiny lesions in the pancreas that may represent precursors. And I think the same is true for MRI. You need high quality MRI and you need really good radiographic interpretation and standardized reporting to understand these. This is a plug for something that we are doing to improve this. So I think all of us are on a mission to find how we can actually find not just a 1 centimeter, but perhaps a 1/4 centimeter or even smaller early pancreatic cancer. And I think this is an area where some of these catchwords, artificial intelligence, deep learning, machine learning, actually are really going to help. We have a very nice data set that on MRI imaging actually shows that the computer, so to say, does do better than we do in detecting some of these early images. And to some extent, something happened here. Okay, some extent, the same is true for endoscopic ultrasound. Okay. I think at the end, everybody wants some blood-based testing, and this is a summary of the currently in trial blood-based biomarker modalities. This is really for early detection of cancer, again, not for precursor lesions. We're doing better. There are definitely approaches, whether it is epigenetic approaches, exosome-based approaches, or protein-based approaches that are kind of getting close to being clinically meaningful in detecting early cancer. Okay, so how do we actually So this is just the final sort of summary of the clinical goals. So this is how we screen for individuals based on the different mutations and different syndromes. Again, imaging, a little bit of laboratory testing with a biomarker called the CA19-9. We typically start recommending individuals who are at risk and have these mutations or a significant family history to start screening at age 50, unless in the very high-risk mutations when it starts at age 35. And screening is once a year. Again, this is a relatively rapidly progressing cancer. So unlike colon cancer, you don't want 10 years of window between two screening tests. Okay. This is a summary of what you actually find in real life. And it's a little bit, it's eye-opening. These are large studies, large cohorts. We're part of some of these publications as an institution. And what you find is when you screen hundreds, sometimes thousands of patients in these cohorts, we find cancer over the time of the duration of the screening program, somewhere between 1% and 4% of the individuals. So it remains rare, not inconsistent with what I told you in terms of fold increase over the general population, but it still remains very much a needle in the haystack. So now talking a little bit about how people do and actually getting access to screening. So one of the questions that I think many of us have been interested in has been, again, this question of who actually gets screened, what actually predicts completion of screening. And this was a very nice analysis from one of the centers led at the University of Chicago of what were predictors of actually not completing screening. And as it turns out, the three predictors of not completing screening, so to say, were younger age and race. And one of the predictors that led to a higher likelihood of completing screening was an actual family history of cancer. How about actually genetic testing in practice? So when genetic testing is, when somebody is eligible for genetic testing, and I told you that genetic testing is kind of the cornerstone of screening for pancreatic cancer, what was the difference in the rate of genetic testing between African Americans and non-Hispanic whites? And as it turns out, the genetic testing rate was significantly lower, nearly half of in the African American population. And most sort of surprisingly, it was actually half as often recommended to patients to undergo genetic testing. So this is the flip side of this. Well, is that because it's a different, the genetic background is different? If you actually look at the prevalence of germline mutation status in African Americans versus or in whites and non-whites, is there a significant difference? And lo and behold, there isn't. The rate of germline mutation status is relatively similar, if not totally similar. So what about studying this patient population? And what about studying patients undergoing testing? Are the studies that looking at the efficacy of screening contain a sort of a sufficiently diverse population? And at the end, top shows, and it's too many numbers to really look through, but the top figure really shows that regardless of what race you're looking at, the uptake of participation in screening studies, which is how we will understand whether this is an effective strategy or not, is the same across the board in the different races. But when you actually look at study participation, how many of each of these, how many of the different ethnicities or races are represented in the screening population, you find what we've already seen in many of the cancer disparity talks, a significant difference in the participation. So this is the last few slides I'm going to say. So one of our goals was to develop, at least on an institutional level, a way that we don't need to rely on essentially some healthcare provider recognizing an individual to be at risk for pancreatic cancer, but rather develop an EHR-based system that identifies, so an electronic health record-based system that identifies, based on a very simple algorithm, anyone who would benefit from pancreatic cancer screening or genetic testing. And so what we did is we collected, so we have 10 years of data in the electronic health record. We looked at 3-year windows. So can we develop a very simple model that tells you that this individual is at risk for developing pancreatic cancer 3 years down the line? We put in, what we did is we took every individual who was present in our health record for a period of 3 years. We put in all of their clinical diagnoses. We put in their laboratory values that were present in a 6-month period and their basic demographic information, and built a model. Our cohort consisted of 500,000 patients. The new onset pancreatic cancer diagnosis was quite low in this. There were 544,000 that were cancer-free. And we did a sort of straightforward case control matching. For those of you who've heard of sort of genome-wide association studies, I like this term. This is a phenome-wide association study, or a PheWAS. Again, I'm not an epidemiologist, so I'm still sort of learning these terms. But this is basically everything that's in the medical record, hundreds of thousands of pieces of information for that individual for 6 months, with the goal of identifying what can we find predictors and a model that defines who will develop pancreatic cancer 6 months down the line. This was kind of sobering and nice. These were the variables that were on the top of the list. And interestingly, many of them relate to pancreatic cancer, what we know about pancreatic cancer risk factors. And then some of them are quite random, which is sort of something that happens, or maybe we just haven't found the associations yet. And so this is how the model did, and it's okay. It's not a great curve, not a great AUC curve, but it's okay. Again, the goal is to be able to say that if you are model positive, you would benefit from germline testing, potentially because you're at risk for pancreatic cancer 3 years down the line. And in fact, this is our sort of risk calculation score. And what it does is that if in our model you fell into the top 20 percentile on the model, top 20% of risk percentile, you had about a 10-fold risk of developing pancreatic cancer than the baseline population. So with this relatively simple model, we achieved this sort of ability to pull every patient who may be eligible for screening. And with that, I will conclude. Again, the main take-home points is that higher baseline risks are currently targeted for pancreatic cancer screening. First-degree relatives of patients with pancreatic cancer screening should have germline testing. Familial pancreatic cancer and germline mutation carriers should be screened with imaging modalities. And I think the different models that include both genome and phenome-based models may help identify additional individuals at risk for pancreatic cancer and potentially reduce disparities in screening. Thank you very much.